Our next speaker, Dr. Nicole Mazwi, invites us to close our eyes and imagine the intensive care unit in a hospital. Are the patients there moving? Are they walking? Well, maybe they should be. Let's listen closely to this talk, Up and Out, Why Early Movement Can Improve Stroke Outcomes. Please welcome Dr. Mazwi.
Thank you, Lisa, for that introduction, and thank you all for your attendance today. I'd like to speak with you just over the next few minutes about a topic that's near and dear to my heart. It's about something that we were all born to do, move, and how moving can change the course of one's life, particularly if done early after a devastating illness. You may be familiar with our motto. Certainly you've heard it a couple of times tonight already. Find your strength. It is a patient-centered, patient-focused goal because a very common thread in the patient experience is the desire to regain independence. Our mission as an institution is to do everything we can to get patients as close to that goal as possible. Achieving that goal demands what I consider the perfect triad of academic medicine: teaching, patient care, and research. I think we all appreciate that medical breakthroughs are really driven by research. And I see research as sort of a cog that really drives innovation in patient care and in teaching. That ideal triad is on display throughout our network. And our care, my job specifically, may start weeks before patients move from one red pin to the other. In the neurointensive care unit at MGH, Massachusetts General Hospital, I'm a part of a team of dedicated clinicians, and we're all really focused on improving the outcome of stroke patients by identifying ways to intervene from an early rehabilitation standpoint. One of those areas is mobility. Our specialty, PM&R, was established and really got its footing around the time of World War II. And this was a period when there were countless young men that were involved in battle and that unfortunately suffered devastating injuries. Before we in PM&R really motivated and created this paradigm shift, bed rest was standard. It was the standard therapy, even to the point of not being advised to lift your head to drink. Fortunately, these standards of care have evolved. One of those standards in our network is in the area of early mobilization. And by early, I mean something that happens in the acute care setting very shortly after an injury. This includes mobilizing patients in bed, providing passive range of motion, getting patients up for transferring around the room, and even walking when possible. Why focus on mobilizing patients? Why am I interested in that? Well, we know that in the immobilized population, that muscle wasting is quite common, and it's associated with adverse outcomes. And in the literature so far, we generally agree that mobilizing patients is quite simple in many cases, and it's pretty beneficial. And this is kind of across the board, no matter the diagnosis. But we haven't established an ideal dose, particularly not in the stroke population. And I believe that doing so will help maximize resource utilization, which we're all concerned about, and frankly improve patient outcomes. This is not an eye test, but I wanted to give you a visual of just how complex the biological underpinnings of deconditioning really are. There's a lot of interplay between disease and physiology in the deconditioned patient. And understanding this is crucial. It's a very important first step if you want to disrupt this process. The complex interplay that I just showed you results in muscle wasting, something that we in medicine call sarcopenia. Measuring sarcopenia provides us with a means of quantifying deconditioning. One valid way to do this is by bedside ultrasound testing. It's painless, it's quite safe, and what we do is measure the cross-sectional area of a thigh muscle called the rectus femoris, which you see labeled RF on the ultrasound to the left. As illustrated in these graphs, sarcopenia is predictive of adverse discharge disposition. That is to say, whether you end up in a high-level rehab facility like Spaulding or in a skilled nursing facility. And we know that implementing protocols to mobilize patients quite early improves outcomes. We have seen this in the data, presumably because we end up decreasing sarcopenia, among other mechanisms. There's been recent prominent work on the impact of mobility in the critically ill population, very ill right after their injury. We relied on this precedent, actually, in designing our own study. And, for example, in the surgical ICU, the surgical intensive care unit, there have been protocols implemented that had a dramatic effect on how well patients do long term. And we're using these same validated methods for measuring sarcopenia as a data point to evaluate the impact of early mobilization. The question is, will such an impact also be seen in the stroke population? While mobilization is helpful, it can be challenging in critically ill patients. However, with a multidisciplinary approach and increasing experience among providers, what used to be absolute barriers, intubation, for example, being on a breathing machine, are now merely obstacles. So I know in this picture it looks like this woman is saying stop, pushing people away. She's actually highly motivated and very engaged in this process, and she's very happy to participate. One very appealing aspect, given my interest in global health, of implementing an early mobilization strategy as a standard of care is that it's quite simple in many cases, and it can really be done in virtually all care environments. So I think about if we can do something in this highly refined, highly resource-rich environment, wouldn't it be nice if we could also do that to the rural hospital in Western Africa that I worked in before I went to med school, or in other very small community centers in Asia and Latin America? Wouldn't that be nice? So what are we doing here at Spaulding? I work here, so I've got to put a plug in. I am leading a multi-center international trial looking at the effects of mobility dose in critically ill stroke patients. My collaborators are just down the road at Beth Israel Deaconess Medical Center, but also in Brescia, Italy, and Munich in Germany. And our goal is to recruit 160 patients over 4 centers, all academic hospitals. We hypothesize that the duration and intensity, which is how we're defining dose, of exercise in the intensive care unit will predict adverse discharge disposition, as I mentioned earlier, but also functional outcomes, how these patients do months down the road, and how long they stay in the intensive care unit, as well as muscle wasting. Of course, we also are predicting that we can actually define an ideal dose. And this may end up that this predicts things in a negative or a positive way. This is what science is all about, answering the questions. Our study population includes all adults with an ischemic or hemorrhagic stroke treated in the neurointensive care unit who were independent at baseline. So this is really life-altering for them. Independent at baseline, and they stay at least 48 hours in the intensive care unit. We've intentionally made our criteria very broad because we'd like to capture as representative a population as possible. Physical therapy and nursing are at the heart and soul and the center of this study. And that is in part because of the nature of the data that has to be collected. That includes the ICU mobility scale, which is shown here on your left, as well as how much time patients spend mobilizing and moving around, how far they walk, and a measure called a functional independence measure, which we use every day here at Spaulding in the rehab centers. So far, I'm happy to report we've enrolled 71 patients. Italy just went live a month ago, so they've not contributed as much, but they will. You could imagine an effort like this takes a small army of people, and I'm actually especially proud to have med students and residents working on this project with us all over the world, not just here in Boston. We've also submitted our first abstract to the International Stroke Conference, and I hope that I am standing to present that in February, particularly because it's in Hawaii. We are sprinting toward our short-term goals, and these include expanding sites, hiring additional research support, analyzing the data once it's collected, and of course, publishing. Many of you will appreciate that in academic medicine, a sprint takes about 2 years. I look at our long-term goals as more of a marathon, and in the future, I'd like to prepare for and obtain funding for an international, multi-center, randomized controlled trial. And I also hope to implement these sort of new approaches, not only locally, but also internationally, given the number of collaborators that are growing across our networks and other networks as well. My efforts would be absolutely impossible without the generous support and encouragement of the folks here at Spaulding and MGH in our research departments, and in particular the patients and their families, without whom this could not be possible. So I hope you'll join me in my efforts to help patients get up and move as they find their strength. Thank you very much.